Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on patterns of lung disease, we are going to be tackling fibrotic changes in lung disease. So pulmonary fibrosis is basically the permanent replacement of lung parenchyma by connective tissue, and this is also associated with functional impairment. The lung is supposed to be involved in gaseous exchange. But if you are replacing normal lung parenchyma with non-lung connective tissue, then no gaseous exchange. So when there is damage to the lung by whatever cause, maybe some kind of a pneumonia or some inhalation of some toxin or some bad inflammatory process going on in the lungs, when there is that kind of damage and the lung tries to heal itself over time, this repair of the focal or diffuse lung injury culminates in pulmonary fibrosis. It culminates in scar formation. When you get a wound on your arm or your leg or something and it's healing, it heals by forming a scar. And this scar is fibrous tissue, right? So that's the same thing that happens in the lungs when you have some kind of lung damage. It heals by fibrosis. And this may be either focal and stable, or it could be progressive following a specific recognizable CT pattern, such that you can look at your CT scans in a progressive pattern and tell what kind of condition is causing this specific kind of pulmonary fibrosis. So, what are the radiological features of fibrosis? In the early stages, you may have very subtle findings like irregular interlobular septal thickening, irregular pleural thickening, or intralobular reticular opacities. Reticular opacities are linear opacities, so you may just see some linear opacities in the lungs. So in this axial CT scan, we see fine subpleural reticular changes and some ground glass opacities bilaterally, and this was also accompanied by some mild bronchiectasis. You can see some dilated bronchi here, here, here. This is suggestive of some early pulmonary fibrosis. We'll come to understand why pulmonary fibrosis would lead to bronchiectasis. In the late stage of pulmonary fibrosis, we have increase in the reticular opacities in the lungs. Also, we have what we call traction bronchiectasis and bronchiectasis. As the name implies, traction means to pull, and bronchiectasis is dilatation of the bronchi, and bronchiectasis is dilatation of the bronchioles. Now, how does this happen? You remember I mentioned that fibrosis is as a result of healing by scar formation, right? So if you cast your mind back to when you've had a laceration in the past, let's assume you have a laceration on your arm that looks something like this. That starts to heal. Remember that as it's healing, it heals from the edge, right? The edge starts to heal and then kind of starts to contract and get smaller and smaller. As it contracts, it pulls on the skin around it until eventually the scar that is left is very small, and you would see that the skin around it has been pulled. The same thing happens in the lungs. When you have the bronchi and bronchioles, let's assume this is a bronchi, and then you have some area of fibrosis here with all this reticulation here and architectural distortion here. As this fibrosis takes place, there is contraction of this area and thus pooling of the structures close to the area of fibrosis, and therefore this wall of this bronchus will be pulled towards the fibrotic area, leading to dilatation of this bronchus. That's how the traction bronchiectasis and bronchiectasis occur. Then we have what we call honeycombing, which is multiple cystic structures in the subpleural region appearing like the honeycomb of bees, and so on. Yeah, so you see this appearance in the subpleural region associated with some volume loss and traction bronchiectasis. This signifies the late stage of pulmonary fibrosis. So in this x-ray, we see small volume of the lungs bilaterally with bilateral increased interstitial markings, most pronounced peripherally, in the peripheries. So you see here, and there's no clear zonal predominance of this interstitial markings. This axial CT scan is of the same patient, and we see extensive honeycombing throughout both lungs in a subpleural and basal distribution. And there's also consequent traction bronchiectasis seen here. It's a little bit here, there's some here, and here as well. So this was a case of late pulmonary fibrosis. When you have lower lobe fibrotic changes, some differentials that you can consider include idiopathic pulmonary fibrosis, rheumatoid arthritis, asbestosis. These will present with a usual interstitial pneumonia pattern of fibrosis. And then you can also have a differential like non-specific interstitial pneumonia as a thought. So in this coronal CT, it shows bibasilar fibrosis and honeycombing with relative sparing of the upper lobes. You can see the upper lobes are relatively spared. And this was a case of idiopathic pulmonary fibrosis. Just an aside, idiopathic pulmonary fibrosis is actually the most common cause of bibasal pulmonary fibrosis. Then when you have upper lobe fibrotic changes, the differentials that you can entertain include end-stage sarcoidosis, chronic hypersensitivity pneumonitis, end-stage silicosis. So this coronal CT shows upper lobe predominant subpleural fibrosis here and some traction bronchiectasis as well. So that brings us to the end of our discussion on patterns of lung disease. The next big topic we're going to be talking about is pulmonary infection. I hope this has been helpful so far. If it has, leave a like, leave a comment, suggestion maybe, and share. Thank you very much, and I'll see you in the next one.